thank you for inviting me to speak this afternoon. I appreciate the opportunity, and I thought I'd begin just by sharing a little bit more about lupus, because that certainly puts things in context from our perspective on how we've navigated COVID and some of the lessons learned from that experience. So lupus is a chronic autoimmune disease in which the immune system attacks healthy tissue. It can affect any organ of the body, but what we see most common in skin, joint, organs. There are three main types of lupus: systemic lupus, lupus nephritis impacting the kidneys, and cutaneous lupus, which is skin lupus. One of the challenges with the disease is it's very heterogeneous in that the symptoms mimic a lot of other conditions. The most common symptoms we see are pain, extreme fatigue, hair loss, cognitive issues, physical impairments, and a number of others as well. And lupus, while it is typically chronic, it certainly can be fatal, particularly when it gets into the organs. On average, it takes about 6 years for someone to get a diagnosis, and that's a challenging process. It involves seeing multiple different providers. And when people are diagnosed, there's a number of different treatments that they may take. On average, around 8 different medications that they take, sometimes as many as 20 or 30, depending on the individual patient. And among those drugs, most are off-label. We have one drug was approved specifically for lupus about 10 years ago. That drug is Benlysta. And at the end of last year, that drug received a new label, or a new change in the indication to include lupus nephritis. So it was just systemic, but now it's lupus nephritis as well. And then we had another drug approved in January for lupus nephritis. So 3 drugs specific to lupus that are out there now. There are up to 1.5 million Americans living with lupus, and 90% are women. Certainly men do get it, but the bulk of the cases involve women, and women of childbearing age, so age 15 to 44 or so. And we do see lupus in children increasingly. In fact, a lot of what we see is people that may not get diagnosed until their 20s, but did exhibit symptoms as teenagers. And lupus does impact minorities at higher rates, particularly African American, Hispanic, Asian, and Native American women are up to 3 times more likely to develop the disease than white women. When it comes to COVID, some of the things that are a little bit unique for us with COVID is that because of the nature of the disease, because we have people with lupus have a compromised immune system, either because of the disease or treatments that they take. And that makes them at greater risk of any infection, but certainly with COVID. Coming into COVID, that was obviously a huge concern. While at the beginning of the pandemic, we didn't realize this, but as things progressed and there's more data out there, with people with lupus, they're at risk of more severe COVID, more severe disease, and worse outcomes. And a couple of the other challenges that we have faced with COVID is that the risk factors that are common, or that make someone at greater risk of developing COVID, are also things that are common within people with lupus. For example, high blood pressure, kidney disease, diabetes, and other things. And another challenge that we faced and continue to face is that the symptoms of lupus are similar to the symptoms of COVID. We had a lot of reports throughout the pandemic of people just not sure whether it's lupus or COVID, and people questioning whether or not they need to get tested, which brings in a lot of other questions for folks. So that kind of gives you a sense of some of the issues that we face coming into the pandemic. And early on in the pandemic, it wasn't, we really didn't know where this was going. We didn't know how significant it would be or how severe it would be. And at first, a lot of our approach was treating it not unlike flu season. in that with people with lupus are very sensitive to flu season and things like that. So hand washing was not, people really being careful of washing hands, distancing, not going to work if you're sick, staying away from people who are exhibiting symptoms. Those types of things were not unusual for someone with lupus. They're very sensitive to the fact that they're at greater risk of catching an infection. So at the beginning, it was really being ultra cautious. Then hydroxychloroquine came along, and I'm going to explain a little bit more about that in a second. But that really changed everything for us. But there's some, and that was pretty much one of the things that was unique to our population, and as well as rheumatoid arthritis, which hydroxychloroquine is also indicated for. But some of the other challenges that we faced were I think common among a lot of conditions, particularly the immunocompromised. But we had challenges with accessing physicians because it's important that people need to see their physician, not simply telemedicine, but it's important to see their physician and to take certain tests that need to be taken to monitor disease activity and provide appropriate intervention. Treatments, the treatments I mentioned earlier specific to lupus, the primary one is an infusion. So people have to leave their home to get it. There is a subcutaneous option for that, but the bulk of people get infused. So that created a lot of challenges too. And the fact that people have to travel. Not everyone has ready access to either a physician, a rheumatologist specializing in lupus, or to get an infusion. So some people do have to travel a considerable distance, which certainly created problems during the pandemic. And as I mentioned, telemedicine, it certainly is a benefit and helped, but it's not a substitute for the in-person visit with a physician. And there's actually some research underway now where we're looking to see what impact the pandemic had on outcomes. Were people delaying accessing care because of the pandemic, and what did that result in? We have a suspicion that it is worse outcomes. So that's kind of some of the challenges we face, but I'm digging a little bit more into hydroxychloroquine and the experience there, because it was unique. And I've had a couple times during my career where I've had these moments where I'm like, the unexpected happens. In a previous position, I was at the ALS Association, and I was there for the Ice Bucket Challenge, which I think most people are familiar with. And that was one of those moments like, wow, this is absolutely incredible and certainly unexpected. Hydroxychloroquine was similar, but for not good reasons, obviously. We did see this coming to a certain degree. There was some research in China looking at hydroxychloroquine early during the pandemic, and we thought that may, if that started to show some promise, that we may have some challenges here. It wasn't until a certain individual, who shall go nameless, mentioned hydroxychloroquine on national television and indicated he was taking it, and that's really the kind of moment for us. And what we saw was pretty quickly shortages of the drug. This is a drug that's been around for 50 years. And it's pretty much the same people taking it every year, same number of people, but we saw an explosion in demand. And the problem, and as I've talked about this experience, the problem wasn't one specific thing. There were a lot of different challenges that we faced. One was a supply issue, just because the demand increased, so we had a supply issue. So that was one challenge. But then we had prescribing issues where physicians who've never before prescribed hydroxychloroquine started prescribing it. They prescribe it not only for their patients, but for themselves. They prescribe it for their family members. We see stockpiling of the drug by every player in the health system, by providers. So physicians and physician practices are stockpiling the medication. Hospitals, health systems, across the board, everyone kind of holding on hydroxychloroquine, and in the process, holding on to it for use in COVID. or for the potential future use in COVID. So a lot of, early on, not much was known about this and its effectiveness in COVID. So people were really anticipating that it'd be effective in COVID. And because of that, they limited the access to it for people that currently needed it. So people with lupus and rheumatoid arthritis primarily. So we saw across the board, and I list at the bottom here, states, health plans, hospitals, health systems, providers, pharmacy boards, all of them in some way were limiting or having a say in who was getting access to hydroxychloroquine. In some cases, they were limiting it to only for use in COVID. They were certainly putting in place quantity limits where people couldn't get a full fill and get 7 days worth, maybe 14 days worth of drug, if that. Prior authorization requirements, where folks had to go through hoops to get it for people with lupus. Or in some cases, you had to have an existing script. So people who were newly diagnosed with lupus and prescribed hydroxychloroquine were having very significant challenges getting the drug. And we had a number of people that just were not able to get drug. So a lot of different challenges, a lot of different parts of the health system played a role in that. And because of that, that required kind of our solutions, and I'll try to go through this quickly. Our solutions were really were systemic, were throughout the health system. There was no single solution. We engaged the manufacturers of the drug. We ultimately ended up working with, I think it was 12 different manufacturers, some of whom that had not previously manufactured the drug. So that helped us to increase supply. There were some other challenges there, which I won't get into, that had to do with foreign supply, and some challenges with India, which there are some challenges there, but we did work with the manufacturers. We also looked for different sources. So not necessarily the large pharmacy chains, but also the mom and pop pharmacies on the corner. And compounding pharmacies as well, and try to find other sources of drug for patients, even all the way down to the local level, trying to direct patients to where they can find the drug. Certainly working with federal agencies across the board, with the main health agencies in the U.S. and the White House Coronavirus Task Force, and then again all the other different players, pharmacy boards, the Hill and state governments. We saw the states doing 50 different things. Some states were really doing their part to help preserve access for people with lupus and rheumatoid arthritis. Some were focused on COVID only. So it was a challenge to try to navigate the states and work with the different pharmacy boards to make sure that our patients had access to the drug, recognizing the broader implications for the pandemic in the broader public. And a big part of what we did was we helped patients navigate the process, create a lot of resources and tools to help them understand what was happening and help them get access to the care they need. But it was a significant challenge. And we're still facing some challenges today, not with hydroxychloroquine, thank goodness. That resolves itself within probably about 2 months, 2-3 months, once more evidence came out about the efficacy of the drug in COVID. So we now have a glut of product on the market, so which is a good thing. But we still have challenges, particularly when it comes to vaccines. And with lupus, the concerns, probably one of the chief concerns we get from patients is whether vaccines are effective and effective within lupus specifically, because we're immunocompromised, and also because of the treatments. There's concern whether the treatments that people take might reduce the efficacy of the vaccines. And then there's certainly concerns with vaccine hesitancy and access to the vaccine from underserved communities and minorities, which are a good segment of our population. So there are some challenges there. And these other two things that I mentioned here, public guidance and reopening, the big concerns here is, and I'm going to get to in a second about lessons learned, but the big concerns here are not simply guidance for our communities on what we should do when it comes to reopening, when it comes to taking the vaccine. A lot of that, because there isn't a lot of information out there, a lot of hard data, a lot of research, is speaking with your physician, which is a good thing and something we always recommend regardless. But the bigger challenge is really communicating to the broader population as we're reopening, and as people are getting out, and that mask mandates are lifted, and distancing, that all that changes. Is that for the general public, that's all well and good, but there's a lack of communication, noting that there's segments of the population, the immunocompromised specifically, who it may not be safe, and that people need to be cognizant of that, of those populations who don't, may not either be vaccinated, or the vaccine may not work, who are generally just at greater risk overall. So that's a concern that we have, and especially as we do reopen, in that there are flexibilities provided for people that are at greater risk, and for people we just don't know the answers to these questions, whether that's school, whether that's work, or whether that's accessing healthcare. So those are some of the challenges that we have, continuing. Some of the lessons learned, I think communication, really getting sound, consistent, coordinated communication across the health system. The hydroxychloroquine example is a really good example of how there's so many different players, and they were doing different things at different times, saying different things that created a lot of challenges. So I think consistent communication and coordinating that within the health system, and making sure that those communications are informed, and evidence-based. Certainly early on, a lot of it wasn't, um, and that was a challenge. But also engaging the communities. Our community, I don't think we really was engaged at the beginning. Certainly not at the beginning, and it was a lot of focus on the general public, which I certainly understand. But I think there were some challenges that we experienced, not just our community but others, that could have been mitigated if we had been brought in earlier, across the health system, not just in certain parts of it, but across it. And I'll also emphasize, and I'll end with this, and kind of pick up on something that Senator Van Hollen was saying, is that it's one thing to communicate with the providers, but it's another thing to communicate with patients and patient organizations, because we have a different perspective. Patients may have a different perspective on certain things than providers and physicians, and it's not trying to say that the physician perspective isn't important. It's critically important, but so too is the patient perspective. And it's very, very important that the patient community be engaged in these issues, because we do have a unique perspective and a unique experience. Thank you for the opportunity. And I'll turn it back over to you.